Hi, my name is Angela, and I am the State's Advocacy Director for Compassion and Choices. Thank you for joining us today. I'm just going to give it a few minutes as people are trickling into the webinar, and as soon as I see the number kind of stay around the same number, we will go ahead and get started. So thank you. Okay, so we will go ahead and get started. I see some people are still moving in just a little bit, but my name is Angela, and I'm the state's advocacy director for Compassion and Choices. And Compassion and Choices is the nation's largest, oldest, and most active nonprofit that's working to expand options, improve care, and empower everyone to chart their end of life. So today, this webinar will be recorded and you will receive a follow-up email next week. We are closed on Monday, so it will probably come out like Wednesday or Thursday with the recording if you want to go back and view it then again. And so I'm so delighted though that we have Karen Warren with us. And throughout the webinar, if you have questions, please feel free to put them in the chat and your questions will come only to us. So feel free to ask whatever you want. We know that a lot of people have questions about medical aid and dying. And then we will either, as we're going through the webinar, I might ask questions if it's specific to something that Karen said, or we'll try to answer questions at the end. So I'm so delighted today to introduce Karen Warren to you. So Karen Warren is an oncology and hospice registered nurse, and she later became or began her healthcare career in radiology and then worked for the manufacturers of CT and MRI equipment. Upon completing her nursing education in LA, Miss Warren worked on the AIDS unit before moving to oncology and bone marrow transplant unit at Cedars-Sinai Hospital in Los Angeles. She has extensive experience as a home hospice nurse, facilitated metastatic and caregiver support groups, and served as an oncology resource nurse at We Spark Cancer Support Center in Sherman Oaks. She has been a healthcare and end of life advocate for over 30 years, and she serves on the board of directors at We Spark Cancer Support Center. Karen is the founder of LA Patient Advocates, which provides education, advocacy, and personal support to Californians at end of life, including supporting medical aid and dying patients and all end of life options. She provides health advocacy for patients and families at any point during their diagnosis or treatment. She had previously served as the South California team leader of the End of Life Options Volunteers for Compassion and Choices and is now part of our South California Action Team. And she's also on our Healthcare Advisory Council, or she's a member of our Healthcare Advisory Council that we have. Karen often speaks to community groups and cancer support centers, has appeared on radio programs, at medical conferences, as well as medical and hospice organizations, all about end of life options in California's medical aid and dying law. And we were just chatting a little bit before this, and she is part of USC did a new documentary that she's part of as well. That will be coming out, I think, in the next month. So Karen was the founding director also of End of Life Choices California. So thank you so much, Karen, for joining us, and I'm going to turn it over to you.
Thank you. And thanks for having me here today. I really, really appreciate it. And I'm looking forward to this opportunity about talking about medical aid and dying here in California and my experience and the experience of our group. As Angela said, I have been involved with the law since it was passed here in California and working towards improving and figuring out what are the best ways to serve patients and their families. So a little bit about our group. It started as an all RN group. And we found that for the longest time, we were helping patients find physicians that would help them access medical aid and dying. And so that's really where we tend to focus. A lot of times we were getting referrals and people were asking questions about medical aid in dying. So we were helping to coordinate and facilitate that process. So we're providing education to the patient and the families. What is medical aid in dying? What does it really mean? And what are the steps involved? We work on all the forms and coordinate the telemedicine visits. We have 5 doctors right now that are available that we are working with. We work with getting the prescription to the pharmacy and the delivering of the prescription, whether it's going to come with us to the patient. And we'll talk about all this as we go through the presentation. And more importantly, we're there with the patient and the family throughout the time, whether they choose to ingest or not. And we offer a grief group once a month for patients, families that have been involved with medical aid in dying. So let's go back to this actual term, medical aid in dying. We hear a lot of different names for it, and we want to make sure that we understand what it is and that we're helping to clarify one of the many end-of-life options that is available. Some of the earlier descriptions of medical aid in dying has characterized it more as writing a prescription because the patient has now decided that's what they wanted. But we want to encompass a little bit more than that. It has a very limited focus if we're just looking at that. We want to make sure that we're there and we're available for the patient throughout this end-of-life journey as they determine what's going to be the best process for them. So there's usually a clinician that's caring for the terminally ill patient who's considering the potential of following through with hastening their death through the use of the medication. Often they're coming to us, they're asking about death with dignity is a big term that we hear patients use. But we want to be able to do what we can so that we can end their suffering and help them die peacefully. These are all patients that are terminal, that have been given a limited life prognosis. And so we want to get some of those records and move forward. Governor Brown signed the bill in 2015, and it was June 2016 that the initial law became legal here in the state of California. And currently there are 11 states that either have the law or are working on trying to get the law passed at this point. So let's look at some of the requirements that would make a patient eligible just to begin considering it. They must be a resident of California, it's usually 6 months or less, 18 years old. And again, that prognosis of terminally ill, 6 months or less to live. And we want to make sure that we're getting some medical records that can follow the patient and bring with them. And they have to be capable of making medical decisions and that ability to self-ingest the medication. If the patient can no longer swallow, we can sometimes use rectal catheters. We'll get that a little bit. But again, it's the patient who is initiating that, pushing the plunger that would help get that medication started. Again, this is all about what the patient wants at this point and how do we help facilitate that. So the law in all of the United States that have medical aid in dying talks about multiple verbal requests to the physician separated by a certain amount of time. At this point in California, it is 48 hours. It's a minimum of 48 hours. So we have our first conversation with the prescribing doctor. Often now, thank you to COVID, we are using telemedicine a great deal, especially with our doctors. There are some doctors that will go to the home and do an examination, but we're doing telemedicine. And it should be documented. Sometimes we'll get patients who come to us, maybe they've been in the hospital and they've had some conversations with their primary doctor about end-of-life options and medical aid and dying. And we'll get these great medical records that everything has been spelled out. So that's great, because that counts as the first discussion with a clinician about medical aid and dying. So we want to have as many of those records that are documented as possible. The written request that the patient is going to sign, and it's going to be also signed by 2 witnesses that are also stating that this is voluntary, that the patient is choosing medical aid and dying, or looking at the possibility of their own volition, and there's no coercion. And then we're going to bring a second physician who's going to be a consulting physician into this process. So it's 3 separate physician visits, and but 2 different physicians. Again, it's voluntary. An institution can prohibit staff from participating. But remember, medical aid and dying is really meant, it happens at home, sometimes in boarding cares, assisted living facility, but it's not something that was really designed to happen in the institution. But often our patients are going to begin asking questions in a hospital about medical aid and dying and death with dignity. When they're facing a terminal prognosis, then they're going to start asking questions, and we want to be able to get them the correct information about what is legal and how it works in their particular state. So we also want systems providing the correct information. So at any time, though, anyone can choose to participate or not participate. So some of the questions we've seen patients get when they bring it up. Recently, I had a patient who was in hospital for a number of weeks, and every clinician he came in contact with, he was asking about death with dignity and using medical aid and dying, and got a lot of shrugs and, oh, I don't know, we don't know how this works. So we really want to help patients get the information that they're really looking for. So all these are not true at all. There are hospices that offer medical aid and dying through the entire process. And any licensed medical doctor, physician can indeed prescribe for medical aid and dying. And so oftentimes you'll hear primary doctors say, well, we'll refer you to hospice and they'll take care of it. But often then it is the hospices that are also calling for someone else to take this process on. So physicians, other requirements that we see, so we want to make sure that our patients understand all the end-of-life options that are available, whether it's palliative care, hospice care, symptom management, other medications that help manage, so that their quality of life is the best it can be. Again, 2 physicians that have confirmed that not only is he eligible, but what is really necessary at this point for them to become eligible, and that diagnosis through the medical records. So 2 witnesses are going to test on this form that would say that this patient is acting voluntarily. And we want to make sure that the patient understands that at any time they can change their mind, right up until the time when we're mixing medications and he's saying, no, I don't want to do this, or I don't want to do this today. I want to do this another day. So in practice, what do we see happening? And again, by and by, we find that patients are very grateful to have this option available to them, and understanding first of all, they want to really understand what the death with their particular diagnosis, what are we going to see and what can they expect? The more information we can give them about the process and what we can be doing to help and ensure that their symptoms are going to be managed, whether it's nausea, vomiting, or pain, that these are all going to be managed so that we can help to ensure the most peaceful death possible and the suffering is going to be eliminated. So this just talks a little bit about the timeline that we work with at LA Patient Advocates. I'm going to talk a little bit about what some other common practices are, but we start by reviewing the medical aid and dying process with the patient. We'll do this both on the phone and we go and see the patient and the family and again explain the steps, make sure that they have written materials so they understand the process and what it really means. And again, reinforcing the fact that they can rescind and choose at any time not to go forward. We're going to do a telemedicine with that prescribing doctor so we can get the timeline going and we know that, okay, now we have to wait 48 hours before that second telemedicine call by the prescribing doctor. We'll set that up both with the doctor and the patient. Anytime in these days, we can get that consulting doctor to make his call, her call, and talk with the patient about why they're considering medical aid and dying and make sure that they understand the implications of it. What does it mean when they drink the medication and what will happen before, during, and after? So I want to make sure that we've explored that a number of different ways and we're able to get this verbal confirmation from the patient. Generally in our practice, the prescription then is sent to the pharmacy electronically and we pick it up and keep it under safe key here until the patient is ready and if and when they use it, and we take it with us that day. By and large, though, and it's common practice for the physician to send the prescription to the pharmacy. And we recommend in those cases, when you're working with someone else, that the medications be held at the pharmacy until the patient contacts the pharmacy and says they're ready within a week to take the medication, and keep that medication at the pharmacy, much better than having it at your home. And things can happen, things are changed. Throughout this process, we really prefer to have the patients on hospice so that any other signs and symptoms that can be changing, and things can change rapidly. Patients can be very lucid and explaining what they want and why they want, and the disease may have a timeline of its own and begin progressing. We want to make sure that we have teams available to manage those symptoms, whether it's nausea or vomiting, or we encourage also showing the patients that it can be 2 to 3 ounces of a powder. The medication comes as a powder, and how we mix it up so they can practice drinking the medication. I'm getting ahead here though. So our attending or the prescribing physician is going to determine the diagnosis, prognosis, making sure that indeed it's a voluntary, that no one is trying to coerce the patient, that they're making this decision on their own. And oftentimes you hear that patients have been talking about this for a very long time, and there is quite a bit of comfort knowing, oh, this is how it's done. This is how I'll be able to get that medication. And then the consulting physician is asking some of the same questions, making sure that the patient is acting independently. And if either the physician or the consulting physician has any question about the patient's capacity, then we would refer to a psychologist or psychiatrist for capacity evaluation. So Again, it does not affect health insurance or life insurance or any contracts at all. We want to make sure that we're all using the correct nomenclature, that it's medical aid in dying or physician assisted dying, not suicide, not euthanasia, and that the death certificate is always going to state the underlying disease. Again, if the patient's on hospice, well, they'll use that hospice diagnosis. So let's be very careful about how we're phrasing it and what we're saying to patients and families about the step. So again, the process in itself is the medication comes as a powder. We're going to reconstitute it with water, apple juice, and it can have a very, very bitter taste. So the more we can talk about this process with the patient and prepare them so they can do some practice sessions. The biggest fear sometimes is that, am I going to be able to get it all down? Is it going to work? And what's that going to be like? Many patients at end of life are not drinking or eating that much as it is, or sometimes we get patients that have difficulty swallowing. So we want to work with them and really reinforce the need to be using some antiemetics and maybe things that they haven't used before. But typically in the regimen for medical aid in dying, we start with Zofran and Compazine is pretty typical. And often we'll get to patients and they really haven't been taking anything, or they haven't been that nauseated, so they haven't been using it, or maybe there's been a change in condition. So they have heard a number of times, whether it's their doctors or hospice workers or other nurses they've dealt with. But patients and families need to hear it multiple times, how important it can be and how effective it can sometimes be to do some round-the-clock dosage. And really, even if you've tried it before, try it again, because we want to get that nausea under control and get them feeling as comfortable as possible. So the day of, we're starting with this anti-emetic regimen and waiting from 30 to 60 minutes. Because of this bitter taste, we try and use some popsicles or sorbet to help the mouth feel especially cold and get rid of some of those sensors so they're not quite tasting the bitterness. We're also using some simple syrup now, and that sweetness has really seemed to help a great deal with a lot of patients. There isn't as much complaint about the taste and the bitterness. So, and the medical regimen right now that you'll hear often, DDMA-PH, the digoxin, diazepam, morphine, amitriptyline, and phenobarbital, comes as a powder, and we generally mix it with the water and the apple juice. Oh, we're not using the other liquid, but generally it's mixed to about 2 ounces and it's thickened. And that's what patients need to be able to get down within about 2 minutes is usually what we're talking about. And the reason is some of the medications are really strong medications and they will fall asleep rather quickly. So if you have a patient that's sipping and sipping, we want them to be able to get it all down before it actually takes effect and they fall asleep. The American Academy of Clinical Medical Aid in Dying is now also recommending a higher dose of especially the Valium and the phenobarbital, especially patients of certain types and certain diseases, so that may have certain tolerances built up. So, but again, sleep comes pretty quickly. I've seen from as little as 2 minutes to as long as 10 minutes. And so if the patient has very advanced disease and is frail, it may be a little more rapid, and younger patients or patients maybe with have used opioids or pain medicine for quite some time, or have a larger body mass, we may see a longer time that it would take. Again, we often mix the liquid directly into the bottle. And I find many patients just are much more comfortable drinking straight from the bottle. We can also use a milkshake straw or a bigger, wider straw. Again, there's been some discussion about this, but the clinicians can mix the medication, but we're going to hand it to the patient. So the patient is doing the self-ingestion. We can make sure that it's not going to get dropped, or we can help steady them. But again, this is totally independent decision. And again, we're going to ask for that verbal confirmation that this is what the patient wants. You want to do this today, we can do this another day. You can change your mind entirely. So having that communication always going is very, very important, both for the patient and for the family. So what will we expect? We expect that we know that it's going to be extremely peaceful and dignified. The patient will literally fall asleep within a few minutes. Very much, or some patients that want to talk and continue talking. And then the average time where a cardiac and respiratory activity begins to slow and stop can be 2 to 4 hours. We're going to talk a little bit about rectal in a second, but the biggest issues that we're dealing with sometimes are burning or bitterness, and maybe bitterness as the medication is being swallowed, and maybe some burning as it goes down the throat and the upper chest. So again, we want to have those sorbets or popsicles near the bed. A lot of times we'll offer a little bit more of that cold that tends to help with the burning and bitterness. And if it's clinically indicated, if the patient is not able to swallow, whether it's a disease process that's happening in the throat, the esophagus, we can use rectal administration. But again, the patient we're going to set it up so the patient can do the initiation of the medication. So we're using a larger 60cc syringe that we attach to a tubing that goes into the rectum, and the patient will push that to initiate the medication going in. Often what I do is I leave one of these syringes available for the patient so they can practice with it and get a sense of what that would be like if they were going to use that. And usually at some point we have an idea that this might be something that we would need to switch over to. Again, it's based on the diagnosis, how much abdominal disease, and the condition of the patient. The medications are absorbed in the lower gut, and we want to make sure that those receptors in the GI system, when patients have not been eating for quite a while, those receptors are not the same, and we're going to see different lengths of time for the medication to be absorbed by those receptors and work the way we would are hoping for them to work. So the night before, we're going to leave some instructions. We're going to ask them the night before if they are eating to have a very light meal, but most of these patients at this point are not eating much of anything but clear liquids. And we'll check them again in the morning to make sure that everything is clear there. And then who is there that day? Usually we like to have RRN, sometimes a hospice staff is there. Sometimes the staff will come after the patient has died. Again, with rectal, we don't need to do the antiemetics. We're not worried about nausea at this point then. So some of the signs to be aware of, and especially when we know that we will probably be looking at a more prolonged time to death, so that we can make the family aware. I think so much we've talked and worked up to this point that now the family is just watching and waiting. So we want to help prepare them time-wise what we may expect. So we know that if the patient has any kind of bowel obstruction, has not been eating, or there's been a slowing down there, or they've been using higher dosages of pain management. And again, our younger patients or those that have been very active physically or overweight, we tend to see more of an incidence of a longer time. Again, it's very individual. We're going to look at the patient and the medical records. And again, it's just a matter of everyone is different. You know, as I often say, we're not machines. We're all individuals. So we just want to prepare what the outside limits may be. But we've been seeing generally a great many of our patients have died within the 2-hour range. But every once in a while, you're going to get outliers for various reasons that may go a little bit longer. You know, when we first started doing this, we were seeing maybe, one patient a month. But in the last year and the last few months, it's definitely been ramping up, and the numbers have been very much increasing for our practice a great deal. And I think, because it's the kind of thing that a lot of patients weren't talking about in the beginning, or a lot of families weren't mentioning. And now we're seeing more of a discussion about, oh, my father always wanted this. This is what he did. And that alone. And there have been more television programs, more movies. So these are some of the reasons that we have seen that patients have talked about wanting to use or explore the option of using medical aid in dying and have that available to them. A lot of times, if you haven't had an experience of death in your family, it's that knowledge of what will happen, what will be like. And the more we can educate patients and families as what to expect, especially concerning the kind of diagnosis that the patient is dealing with. What would we expect death would be like in this case? And what we can be doing to help to make sure that the symptoms are well managed and they're comfortable and they're able to get some of the best quality of time possible. So sometimes just having that prescription or knowing that we're working on it's going to be available can be a very, very big relief. Many patients will see me walk in the room going, what, you don't have it? You didn't bring it with you? And I think having that discussion about these are the steps, these are what we need to do, these are what we want you to be able to consider about the process. But while that's happening, these are other things that we can be doing to make sure that you're comfortable and that you're getting everything that you need to be as comfortable as possible. And I don't think anybody has the right to extend someone's dying or suffering. And that's what we want to be able to do, is be able to take as much time as possible, understand what this particular patient and family are going through. What can we do to make sure that as many symptoms as possible are being treated, eliminated, helped, and that we're always there to answer questions at any time. We're available 7 days a week. We want them to know that as things change, we're going to be there and support them. In conversations about end-of-life options and really what their choices are can be so empowering, especially patients who have been ill, whether it's a short time or a long time. They know it's a life-altering time for all of the family. So we want to do as much as possible to let them know we're there, and to help answer whatever questions they may have. Medical aid and dying is not a failure, but it's a patient choice, or CHO. I think we missed some of those there. And we want to make sure that we're working to help them understand what all their options are, and that we're going to be there to help them throughout the process. Angela, Leslie, are there any questions?
I do have questions. There's Karen's information on the screen. Thank you so much, Karen. We have quite a few questions. So if you do have a question, please, you can chat it to us, and it will come directly to me. I'm the only person who can see it, so don't be afraid to ask anything. Um, so please go ahead and do that. One of the things I wanted to talk about is somebody asked specifically about Kaiser. And Karen, I don't know if you want to say, I'm sure you work a lot with
Oh,
Southern.
yes, yes. So when we're talking about the process in general, and when I talked about, what our steps were. So at one point early in the law, it was 15 days between the first and the second visit. And a lot of the larger institutions, not just Kaiser, some of the UCLA's, UCSF's, a lot of the bigger institutions, they're bigger, they have more steps involved, and it can be much more burdensome, or because they have to make appointments with multiple doctors. Sometimes there is a legal system in place. So we get many calls sometimes for people who have been in those systems, but they want to get through the system a little bit further. So we're a little bit leaner. We can mobilize a lot quicker. But yes, Kaiser does honor, they were right there in the beginning and have a medical aid and dying. UCLA, all of them have programs in place, and you just have to make sure that you understand from the beginning, what are the steps that I need to get in place? What appointments am I going to need to do? And how do I get through those steps? And they each have departments that can help you find out what those are. And many times, Kaiser is also using outside hospices. Again, when we encourage patients to be on hospice throughout this process, because if there are changes in conditions, and conditions can change rapidly, it can be at night, it can be on the weekend. Hospice is 24/7. You can call them. Oftentimes they know what's about to happen. What do we expect to happen? And so we want to make sure that they can have access to medication, that they can help send them, or know that, okay, this is what we can take to help eliminate, whether it's nausea or whether it's an increased level of pain, whatever is going on, so that we can make sure that the quality of life and the comfort is maintained to the best of their ability.
Yeah, and I just want to also say, because we have heard this, I know at Compassion Choices, um, I know that some of the larger healthcare systems, also Kaiser, they have like MAID navigator programs. But specifically at Kaiser in Northern California, one time somebody contacted us trying to see if we could help them find like a provider or someone who would be able to help because they were a patient at Kaiser. And sometimes it's just such a large system that maybe your doctor doesn't even, in this person's case, and I've seen it happen other places in other states, where like the doctor doesn't even know about medical aid and dying. And so this person was a patient of Kaiser, and they came to us looking for someone, and we were able to connect them to the MAID Navigator program. So if you are at, I think Karen mentioned this too. One of the things you can do is is like if you Google like what is the medical aid and dying policy for the name of the healthcare system, they're supposed to do a policy on their website, but they're by law, but there isn't any kind of like teeth behind it. So a lot of systems don't have it, but a lot of the bigger ones will have their MAID policy. If you just Google, I see somebody mentioned Sutter. So Sutter Health made medical aid in dying policy that will pull up. Um, and then same with Kaiser, and same with some hospices too that will pull up. So, but Kaiser has told me it will take pretty much a minimum of 3 weeks to go through the process, and that's if everything goes smoothly.
Yeah.
Like nobody's on vacation or anything. So,
And that we've had that patients come to us with exactly that situation. Someone's on vacation, there's another signature, the same way with UCLA. So, we're able to be a little more flexible and move a little bit quicker. But again, if you're already in that system and you don't have to pay for some of these appointments, that can make a big difference. We have to charge because we're paying our doctors, we're paying our nurses. So, there is a fee involved. So it's that getting within a certain amount of time. And we've done it with a few weeks. Yeah. And some of the bigger systems too, it's just a matter of being able to get into an appointment. But I think telemedicine has really made a big difference. And if it comes up again too about being able to dispense drugs, we're hoping that we always get to keep that exception for death and dying and terminal or hospice patients, because it is special. You shouldn't have to be going from door to door to do that and get what you need at that point.
yeah, and just to clarify, because somebody asked, why does Kaiser take 3 weeks if there's only a 48-hour between the first and second request? And again, so that is just making your request. So you have to get your appointments with your doctors to make the request. You have to meet with a consulting provider and then meet with a pharmacist and get the pharmacy meds. And it is a compound medication. So that takes a while for that to happen. So it's just because Kaiser is a larger system. It's one of the first things that Kaiser said to me when I met with them, was like, we think it's great that the request has been shortened to 48 hours, but people often come to us thinking they can get it within 48 hours. So like help us get the word out that, because what the reason why it was reduced was because a lot of people were dying during that 15-day waiting period. And so Kaiser really wanted to get the word out that like just because the minimum mandatory waiting period has been reduced, it doesn't mean that you will get your meds within 48 hours. Karen is probably with the LA Patient Advocates is probably, especially too when they said same thing with Sutter. Thank you, Stephanie. I see you in there. Again, just larger system. Sometimes we have people contacting us, and I think a lot of times people don't know that it can be such a process, and they are very close to death. And usually, I just call Karen and say, "Karen, can you please help?" And she just has always bent over backwards to try to be helpful.
Well, thank you.
But did
Thank
you?
you. I think it is important to realize if it's something you're talking about, we get the medications, whether we're storing them or the pharmacy is storing, but they're good for 6 months. The prescription's good for a while. And it's good for 6 months. And if for some reason the patient hasn't taken it 6 months and they're still eligible, someone's going to write another one and we can get another one. So it's way better to start the process early and get it moving if you're going to go through one of these bigger systems. One of the things we've run into with one of the big systems was the patient had started with the system and we thought, all right, we'll come in, we'll see if we can streamline it and get it done in 48, 5 days or whatever. And the doctors who associated with the big system now won't write or sign anything unless you're going with them for the whole process. So that's something to be aware of. And the forms that we're talking about, we can get online, we can get them to you. You can also take them, especially for the consulting form, into one of your doctors. It's a one-page form. All they're saying is, yes, the patient's terminal. They understand what they're asking for. The consulting physician is just confirming basically the diagnosis, and the patient has the capacity. And so that can be helpful sometimes. But yeah, no, and the pharmacy we use, he's wonderful. And we're really, if we get it in, we're able to get the medicine in 24 hours and often the same day if we say, look, this is someone who needs it. And And there are patients who come to us who are very ill and they want this and they want to be able to have it in a certain day. I think that's the other thing. Sometimes people say, well, how will I know? What will I know? How do I pick a day? So, but again, for the most part, I always say you'll know because it's time. Your body's going to tell you, you're going to know emotionally that you've been through as much as you can do. And people always say, oh, you're right. Today's the day and I don't want to wait another day. So, there, take your time, but look and find some place and get it started earlier. You can always stop. You can always change your mind right up until someone's mixing it, and even then, you never have to take it. It's totally up to you what you decide to do.
And I want to highlight, I have a lot of people asking too about what areas you serve and the cost. Somebody real quick before I move into that, Providence does not participate in medical aid in dying, and a lot of the Catholic religious institutions do not. If you go to Cedars-Sinai's webpage, like I said, if you were to Google Cedars-Sinai medical aid in dying, they do have a policy on there. So it is possible to get it through there. And again, it's really asking your doctor. And then again, it can be tricky because sometimes doctors don't know. So that's why I'm really encouraging you to, whatever healthcare system you're involved in, if this is something you think you might want in the future, I would go ahead and try to Google it with medical aid in dying policy and see if that will come up with their policy as to whether or not they support you. You can also ask your doctor and they may or know. So Karen, can you share, do you just serve people in the LA area?
Yeah, but I do want to mention too, I have had a number of patients on Providence, both Providence and Providence Hospice, but it doesn't mean that you individually as a patient can say this is what we want, and then we do it separately. So just because you're on Providence Hospice does not mean that you cannot, it's the law in California says anyone who wants it can use medical aid in dying. So and at any time you can change hospice. It's not that difficult to do that, is to make a phone call and they take care of everything. And that was really how we got started with this LA Patient Advocates, that I basically was often telling patients, so let's switch you over to a hospice that will do this. And a lot of the patients go, well, I don't want to change. I like where I am. I like these people. And so I was lucky enough to find doctors who are really willing to get on the phone anytime, any day for a few minutes, look at the records and help to move things along. So yes, don't get discouraged by where you are. Just speak up and we can help advocate for you. So I'm sorry, what was the question?
Do you just serve the LA area or?
Yes, yeah, mostly Southern California. We go up as far as, Ventura and east to Palm Springs and down to Orange County. So we do have a couple of nurses that have come on and help us fill that area. So yeah, so.
What about like Northern California, San Francisco Bay Area?
Oh, we are plenty of hospice nurses, so we know nurses up there. We can connect you with people up in that area and physicians up in that area.
Yeah, and I think too, because I think the key that we're missing here too is that Karen uses telemedicine a lot too.
Yes.
So she can get you connected with doctors over telemedicine as well.
Right. So nurses and doulas in other areas, but yes, as long as it's the state of California, we have doctors here, we can get that set up. No, and Medicare and health insurance do not cover this. This is all separate. It goes into this whole long, Medicare and assisted, whatever phrasing we're going to use. So at this point, it doesn't cover it. So that's important to know. So that's why if you can look at some of the forms and have maybe your family physician or someone, oncologist or someone you were working with, fill out a couple of the forms, then that sort of helps to take down a little bit of the cost for us too. And we'll work with everybody. We're not going to let anyone who says, oh, this is what they want. There are some foundations that help with pain, and there's a couple of hospices I know that have foundations that will help. So please, please let us know, and we will help make it happen.
Thanks, Karen. And what can you talk a little bit too about your, I know you said that, so I don't know if you want to go into like general pricing, but then somebody also asked about the cost of the medications.
Well, we have an amazing pharmacy right now, and the medications around $400. So and that's here in Southern California. So I know people are, it's $700 some other places. I haven't really looked in a while because we've found a great pharmacy that's been really responsive and has a really reasonable price. So and again, they'll ship it, so we can work that out with what they need. And then the other costs are the physicians for the telemedicine. Then so again, but we know hospice is covered by Medicare. So if we can get the hospice in and the nurses there, so a lot of times we want to understand what hospice policy is. Can they be there during medical aid and dying? If not, then you'll have someone like LA Patient Advocates or a doula who will be there. Then the big part tends to be the mixing of the meds. I find that patients don't want family members touching or mixing them, and they want to feel like this is their thing, that's separate. So we tend to do the mixing part and then let the patient is in charge of the ingestion part. We also have a grief group once a month for families that have a family member who has used medical aid and dying. Sometimes they may go to other bereavement groups, but they find that they're not really able to talk about the medical aid and dying component about it. A lot of it tends to be people are, the process of finding it and getting through it, or wanting to be able to honor their loved one because, hey, this is what they wanted. How can I make sure that they get what they want at end of life? So that has really been very helpful, and we've gotten a lot of information from that.
And then Karen, we have some questions too about, and I think this is just what you do within your practice. But so about you keep, I think someone said that you keep the medication, but other people are saying that they thought that a person could obtain the medication and keep the medication even months ahead.
Yeah, we don't really recommend that, and most organizations don't recommend it. We think the best place for the medication should be the pharmacy. Don't get the prescription filled. Again, all that in California, everything goes electronically to the pharmacy. And then you can touch base with the pharmacy. If you're not working with a group like us, you touch base. Don't have the pharmacy fill it till you're within a few days of when they want to ingest or use the medication. It's not a good idea to have it around in the house for a long period of time. And then you could even have, someone like us pick it up and bring it there, or have a family member. I know there's one big institution where the family member has to come in and, get an explanation and get the meds. But again, that can be done by telemed, explaining that whole process. So, but yeah, we have a giant safe here. We keep meds in a safe. Sometimes that'll be an extra cost that they want to provide, like a little safe or a lockbox for it. But remember, if you have someone who's terminal, who's been suffering from cancer, you already have a lot of, very strong medications in the home. So it's about keeping everything up and away and safe, and knowing what you have and who's taking what when. But yes, so we recommend the pharmacy is the best place until you're ready for it.
Yeah, and I'll just share too, because we have a storyteller, and I think this kind of goes to what this person was saying. But his wife used medical aid in dying. She was dying from cancer, and she was not on hospice, which that can be a whole other thing. But in his case, it worked out kind of well because he was a volunteer firefighter. So when the fire department showed up, it was all of his friends. So it was actually really nice for him. But she did have the medication with her. And somebody also asked, like, do people seem scared before they take it? And similar to what you said, I think of his story a lot too because his wife, she had the medication with her for months, and then one day they said, how will we know? What day will it be? And she's like, I think I'll just know. And he says the day she woke up, and she said, today's the day. And they had, a lovely ceremony. The two of them went out to the farm, and then she took the medication. And he remembered thinking, how does she know that today's the day? And then he shared with me later, he went back and looked at the photos from her from 6 months earlier. And I think when you're with somebody every day, you don't see, the changes in them.
And it's changing. Yeah.
Yeah. And he said when he looked at 6 months earlier, he's like, oh, I could tell then when I looked at,
See that.
did the side
Yeah.
by side that, she was right, that was her day.
Yeah. And sometimes if there's a big family too, we may start looking at a calendar and dates because the patient may not understand that, oh, today's the 11th, but for another family member, that 11th is significant for something else. So sometimes if you start talking about some of those days, now again, depends on the patient and the diagnosis and the severity of what's happening. But sometimes it's very important for them to be in tune to that and what implication these dates or choosing a date is going to have on the rest of the family too, and that anticipatory grief that they're experiencing. But no, by and large, everyone has been sick, very sick, and they're very ready. And I think that's why having a clinician there who's really looking for those kind of signs and know that patients are ready, and this is there's no waffling. It's today, and we can always come back another day. There's nothing magical about today. They can change the mind and do it another day. But
I'm going to ask you two more questions, and one I can talk to a little bit too. But a few people are asking if you also help with voluntary stop eating and drinking.
yes. We work with patients who are using that. But with medical eating dying, we see it less and less. And again, many times patients, as their bodies are shutting down, that they are not eating and drinking, that the amount of intake has definitively shut down. Those who've chosen to stop, so then we want to make sure that they're on hospice and that they have good support systems, whether it's family or hospice, so that if they need any other medications, it's available.
Okay, I lied. I have one more question before I answer another question. So somebody said, what about diagnoses that are terminal, but for which a 6 month term before death can be harder to predict, like heart failure, stroke, is it some strokes? And they asked about dementia, and I'm gonna go into that and answer that right before we close out.
Okay.
But heart failure, let's just say.
Well, I mean that there are other medical and signs and symptoms and heart failure, ejection rates, so we're looking at the medical records and what do the signs and symptoms in the medical records tell the clinician about the patient's status. It's not like one catch-all frame is, what's happening with that patient and how far along, there's end stage, there's different stages to heart failure and COPD and even stroke. Often we're looking at, the ability to swallow and some of those other things, because remember, in the United States, we're focused on this GI system. So it's a matter of, can they swallow? Can they make a decision? Do they understand what their diagnosis, prognosis, and what the consequences of their decision is going to be? And I think that's what works really well with us with doing telemedicine by having an RN with the patient during the telemedicine. What are we seeing? What have we observed in our evaluation that can help the doctors to make that
Thanks,
diagnosis?
Karen.
Yes.
It is 1 o'clock, so we do have to end, but I do just want, because I feel like a few people were asking this, and so I do just want to highlight this. So if you have been diagnosed with dementia and you have terminal cancer with 6 months or less, and you have been diagnosed with dementia, but you still have your decision-making capabilities and stuff, have a conversation with your doctor to see if you're eligible. If you have only been diagnosed with, Alzheimer's disease or type of dementia, and don't have any other terminal illness, you won't be eligible for medical aid in dying. So there are safeguards in the law, and legislators and physicians really are a lot fonder of these safeguards. Um, that you have to have a 6 month terminal illness and you have to have decision making capabilities. So by the time, if your only diagnosis is Alzheimer's, by the time you have a 6 month prognosis with Alzheimer's, you won't have your decision making capabilities anymore. So you're not eligible for medical aid in dying. And then there are some other questions about, being able to self ingest, and then other countries that the doctors can use IV and do it that way. So in the United States, that is what we call euthanasia, right? When a third person would be doing it to you, that is illegal everywhere in the US. So that's why it's really important that the person's able to self-ingest the medication. And so again, we will send this out, the video of it, and Karen's information is in it. So if you want to contact her, you'll have that information. You'll get the email sometime next week. Again, we are off on Monday, so it'll probably be closer to the end of next week. Just things that we have to do on the backside to get the email out. But thank you so much, Karen, for taking the time,
Thank you.
and really everything you do to advocate for this and helping people just have a great experience. So
Thank you. My pleasure. I'm glad I can help. I really am. Thank you.
thanks, Karen. Bye, everyone.